Firstly, I'd like to thank the conference for the opportunity to present this work on behalf of the ODYSSEY trial. So the data from this study came from the ODYSSEY trial, which evaluated the efficacy and safety of dolutegravir-based ARTs versus standard of care in children starting first or second line treatment. They recruited into 2 weight cohorts, and they had a primary outcome, which is a composite of clinical and biological treatment failure by 96 weeks. Dolutegravir showed superior efficacy in both of those weight cohorts. Now, the focus for this study is on those in the ODYSSEY A cohort, which is those starting first-line ART. In terms of population, 381 ODYSSEY participants were included in this study, with a median age of 10.5 years, a median CD4 percentage of 20%, and a median BMI for age Z score of minus 0.58. 73 participants had an ongoing WHO stage 3 or 4 event at ART initiation, which included 40 with tuberculosis. Those on standard of care, for those weighing greater or equal to 14 kilograms, the majority were on efavirenz, and for those weighing less than 14 kilograms, the majority were on lopinavir. As you can see from the figure on the right, the majority of participants were recruited in Africa, but some were recruited in Europe and Thailand as well. By 96 weeks, 75 children experienced treatment failure, 77% of which met the virological endpoint definition. In terms of methods, predictors were assessed using Cox proportional hazard regression models. All models were adjusted a priori for trial arm and age, and first-degree fractional polynomials were considered for continuous variables. Domain-specific models were selected using p less than 0.2 for retention, and then a full joint model was selected from domain-specific predictors, with p less than 1 used for retention. And bootstrap resampling, finally, was used to assess the robustness of these models. On the screen here, you can see all of the characteristics at ART initiation that we looked at and we assessed. So we looked at anthropometrics, HIV markers, hematology, and demographics. The variables that are shown in bold red font are those that were retained in each domain-specific model. And we found that low BMI for age, low CD4 percentage, an ongoing WHO stage 3 or 4 event, higher neutrophils, and being at an African site were independent predictors of treatment failure in these models. We then took all of these independent predictors, so those that I just mentioned that were retained in the model, in the domain-specific models, and we considered them in a joint full model, adjusted for trial arm and age. The variables that you can see are circled in green, so trial arm, age, BMI for age, and CD4 percentage were retained in this model. We found that for those on dolutegravir, the risk of treatment failure was 53% lower than those on standard of care. For each additional year of age at ART initiation, the risk of treatment failure decreased by 9%. For each 1% increase in BMI for age Z score, 1 unit increase in BMI for age Z score, the risk of treatment failure decreased by 23%. And for each 1% increase in CD4 percentage, the risk of treatment failure decreased by 2%. On the right-hand side, you can see the results of our bootstrap resampling. So as I said, this was done to assess the robustness of models. The bottom line is that the higher the inclusion percentage you can see in that graph, the more robust these predictors are. And you can see that BMI for age and CD4 percentage are highlighted in green because they were selected in our final model on the left. And you can see that they're selected in over 60% of bootstrap models each, indicating they are strong, reliable predictors. But what's also interesting is you can see the 3 variables which are highlighted in black. So ongoing WHO stage 3 or 4 events, neutrophils, and region, were still included in around 50% of models, bootstrap models, even though they weren't selected based on significance in our full model on the left, which still shows us that these variables are still important predictors. On the next few slides, I will show some graphs which are survival curves estimated from the final model. So first of all, we can look at treatment failure by trial arm, and this was estimated using a median age, median CD4 percentage, and a median BMI for age from our population. What you can see is a clear divergence between those on dolutegravir and those on standard of care to 96 weeks, as you might expect. And if we look at the table, you can see that those on dolutegravir had a 10% risk of treatment failure by 96 weeks, compared to those on standard of care that had just over double that, so a 21% risk of treatment failure. Now, importantly, we found no difference in predictors by trial arm. We didn't conduct a full analysis in only those on dolutegravir because of a small sample size, but what we did do is we fit the final model into only those on dolutegravir and only those on standard of care. And what we saw similar hazard ratios between those two groups, indicating that the effects of age, BMI for age, and CD4 percentage were similar on dolutegravir and standard of care. We can now look at treatment failure by different age profiles at ART initiation. Again, these were estimated using the median of the other predictors. On the left, we can see this in the standard of care arm, and on the right, we can see this in the dolutegravir arm. You can see for both arms, the general trend is the lower the age, the higher the risk of treatment failure. If we focus on the dolutegravir arm on the right, and particularly the table, we can see for the average child of age 1, the risk of treatment failure by 96 weeks was 23%, whereas for a child aged 12, the risk of treatment failure was only 9%. We can see a similar pattern for CD4 percentage. Again, standard of care on the left, dolutegravir on the right. The general trend being the lower the CD4 percentage, the higher the risk of treatment failure. And again, we can look at the dolutegravir arm. For a CD4 percentage of 15%, the risk of treatment failure was 11% by 96 weeks, compared to a child with a CD4 percentage of 25%, where the risk of treatment failure was slightly reduced to 9%. And finally, we can see similar graphs for BMI for age. Again, standard of care on the left, dolutegravir on the right. And you can see that the lower the BMI for age, the higher the risk of treatment failure. And you can see a nice divergence of those different profiles of BMI for age Z-score to 96 weeks. And again, focusing on the dolutegravir arm, we can see that for an average child with a BMI for age Z-score of -3, the risk of treatment failure was 19% by 96 weeks, compared to a child with a BMI for age Z-score of 1, where the risk of treatment failure was only 7%. Now, this last graph that I'll show you is a high-risk versus low-risk profile. This is only on the dolutegravir arm. And what this graph shows is the comparison between a child aged 1 with a CD4 percentage of 20% and a BMI for age Z-score of -2, to a child aged 12 with a CD4 percentage of 30% and a BMI for age Z-score of 1. And you can clearly see there's quite a huge divergence between these two profiles to 96 weeks, with the cumulative effect of younger age, a relatively low CD4 percentage, and a low BMI for age Z-score, resulting in a 31% risk of treatment failure by 96 weeks, compared to the low-risk profile, which only has a 5% risk of treatment failure. The last thing I wanted to show you was an alternative virological failure definition and what the model would look like under this alternative definition. So the ODYSSEY primary endpoint was a composite primary endpoint, which included virological and clinical failure. Most virological failures, so 97%, were defined as 2 consecutive viral load measurements greater than or equal to 400 copies per milliliter after 36 weeks. 84% that have met that original definition also had 2 consecutive viral load measurements greater than or equal to 1,000 copies per milliliter by week 96, either at the same time or slightly later. So we wanted to see whether these predictors differed and whether we ended up with a different final model. What we found actually was with this higher threshold of virological failure, the predictors were the same, but in our final model we also had an ongoing WHO stage 3 or 4 event included. And so to summarise, children receiving dolutegravir-based ART had a significantly lower risk of treatment failure to those on standard of care. Other predictors of treatment failure were the same on dolutegravir and standard of care, and they included younger age, lower BMI for age, lower CD4 percentage, an ongoing WHO stage 3 or 4 event, and higher neutrophils. Now, these findings can help clinicians identify children at higher risk of early treatment failure and provide the basis for an online tool that may help clinicians so they can enter these characteristics when children are starting treatment and be able to predict their treatment failure risk by 96 weeks. And so future research should evaluate interventions such as non-oral ART, enhanced treatment, adherence support for these high-risk children. And so I'd like to thank everyone that's been involved in the ODYSSEY trial and continues to be involved in the ODYSSEY trial. Thank you very much. I'll take any questions.